the choice of the speakers and the faculty that you have. I have known Dr. Asha Jain for many years as a very sincere person, someone who's very dedicated, not only to the work that she does, but also to the institution she works with. And Asha ji, let me wish you the very best as you go forward in any leadership position in Foxy. I'm also delighted to share the forum with Dr. Mandakini Meg. Madam has always been a great support to all our members. I have always said Dr. Meg is our person in the government. And whenever anyone needs help with anything in the government, Madam is always there and ready to help. Charmila, of course, is such a wonderful person, such a sincere person. And I'm really looking forward, Charmila, to working with you in the next year. I'm not seeing Dr. Asha Bakshi, but again, someone who's very dynamic, very knowledgeable. And I must again congratulate Asha ji for the wonderful panel that you put together. Jyoti is the expert, Dr. Shabana is co-moderator, and such a wonderful set of panelists from all over. Dr. Nagar, Dr. Srivastava, Dr. Panse, Dr. Gupta, Dr. Shruti, Dr. Ruchi, Dr. Alka. And in the second panel, Dr. Brajbala, Dr. Jyoti, Dr. Runda, Dr. Renu, Dr. Maheshwari, Dr. Shweta, and Dr. Anuradha, with co-moderator Dr. Sadhna Mehta and expert again, Jyoti. And I understand, Dr. Asha Jain, you have a very hectic couple of hours ahead of you because you're going to moderate both the panels. So I will step out of the way and let the audience enjoy the two panels that are going to follow. Thank you very much again for having me. It is my real pleasure and privilege. Thank you.
Thank you, sir. Thanks a lot for those words of encouragement. And very few of my panelists have actually joined in. So let us see how it goes. I actually did not have an introductory lecture because I wanted 4 experts are here. You are there, Charmila is there, Mandakini ma'am is there, that you would actually give the basics and then we would just take the panel forward. So thank you, sir. Thank you for being with us. And now I have Dr. Mandakini Meg ma'am, who's the past chairperson of ICOG. Ma'am, I'm very honored to have you here. I know you're always with MP and Chhattisgarh. She was the chairperson of ICOG Foxy 2020 to 21, President Association of Medical Women of India Central Council, International Vice President MWIA Central Asia, National Vice President Foxy 2012 to 13, member of FIGO Committee on Infections During Pregnancy, member of AOFOG Reproductive and Sexual Health Committee, past president of Indian Federation of Ultrasound and Medicine and Biology, past dean of Indian College of Medical Ultrasound, chairperson of Imaging Science Committee, deputy director of Health Services, Government of Maharashtra, advisor.
Yes. Everybody has heard those biodata last year.
Thank you, ma'am. Thanks a lot. And we seek your blessings.
Yeah. So can you stop sharing, please? Yeah. 1 minute, I was. So good evening, Asha, Charmila, Dr. Jaideep Tang, all my I can say Maike people like Ujjain, Indore, Bhopal, Raipur, Chhattisgarh, and Jabalpur. All these people are mine because I am educated in Indore Medical College, very much product of MP, and also my Maika is in Ujjain. So I think always feel like coming home. As Dr. Jaideep has set the mood of the today's webinar. Very important. I think Sharmila will agree with me. We have been discussing this particular topic, postpartum hemorrhage, day in and day out. It's a perennial topic, and I think it is because of our repeated discussions, webinar, so many focus conferences on PPH, the maternal mortality rate by PPH is coming down. And we are very proud to say that even in India, like Maharashtra and Kerala are the 2 states which we have achieved already 2030 target by 2 digits, that is a 3032. But I think, Asha, there is much more things has to be done because this PPH care, And we have this formula of 70-30 with the FIGO, that in 70, there should not be any deaths, 70% deaths by PPH and 30% by the maternal mortality disability by the PPH. So this is our formula. And most important focus, I think you are going to discuss. We have wonderful panelists here. But important is two things which I would like to say. That is the latest thing which are going to come. We are already discussing, that is a postpartum quality care. And second thing is important is a PPH bundle. Hi, Shruti. Hi. So PPH bundle. So this care, I think we have discussed at many forums, all of us are aware. But what is lacking is that still there are so many things to be done. But even in rural India, till today, I think everybody is seeing the newspaper, the Adivasi person was being carried out, they die at the door of the hospital. So we have to stop those preventable deaths. So in my opinion, communication, readiness of the facility. Because whenever we say, patient bhej rahe, so your headache is off. But actually when they go there is no readiness. So this readiness of the facility, training of those people who are handling that, supply, very important. Even in the this present government and on any government, GDP, supply of this thing is very, very important. And these three things will always remain. And the transport, that is a referral. So these four things, I think you must discuss in your, this program, because these are non-medical interventions, which are very important. And I think with the AI and things like that, which are coming, there will be a speedy communication. There will be instant mobile apps also. Already they are there. But I think this will reduce the burden of deaths due to the PPH. That is my frank opinion. Being the deputy director and director of family welfare, I have found this. And one just example I want to tell you, that whenever there was any patient to be transported, the facility was never ready. And one incident I want to just narrate to all my people who are seeing. Once when I was in Mantralaya, there was a challenge given to me, Madam, Dr. Meg, tell me what are the drugs which are available at the primary health center. So I told my principal secretary, you just find out from DHO that the methergine is not available. That time methergine they were using. They said, no, it is not possible. I said, please check, madam. And then what we found out from one DHO, no methergine, only IV salines and all. Because, so nobody gave the importance of proper, supply of the drugs, which is so important. So I think with this, Asha, I wish you a very great program. Keep on doing it. Keep on inviting us also and everybody. And Charmila, you are going to have a great year with our very dear Jaideep. You will make us proud always. And Asha, very best for you. Whatever there, I am there for you. Chhattisgarh MP is in my heart. Whatever help is required, Shruti, you know it, that we are there for everybody. So feel free to contact me and I'm always there for you. So thank you very much for this kind invitation.
Thank you. Thank you, Mandakini ma'am. Your words really mean a lot. And everybody knows, even Jaideep sir said that you're always there whenever any government intervention is required. Yeah. So now I would like to welcome my dear friend Charmila. She is the Vice President-elect FOXI 2024, Chairperson Clinical Research Committee FOXI 2016 to 18, the ICOG Governing Council member 2021 to 23, National Coordinator UNICEF FOXI PCA, MEDHA FOXI PG Program, ISAR Gurukul Program 22 to 23, Series Convener ICOG Journal Club and ICOG Certificate Courses 22 to 23, WHO Southeast Asia Region, MDSR India member, Past Secretary Trichy Society, President Menstrual Hygiene Management Consortium 2018 to 20, Joint Secretary Gestosis India Association. More than that, I've seen her in her campaigning time. She is a really knowledgeable person who's always ready to help you out, always ready. Previously, I called her in any number of webinars. She was always there as an expert. So welcome, Dr. Charmila. Over to you now.
Thank you so much, Asha. It's always an honor to be in a program where Dr. Jaideep is the chief guest and my teacher, Dr. Mandakini Meg, is the guest of honor. Dr. Jaideep Tank was an inspiration for me to become a chairperson in Foxy, and I was desperate that I should get into his tenure so that I learned from him. And Meg Madam has introduced us to Foxy even as postgraduates, because Kama Hospital, 6th floor was Foxy office. And she used to provide us with books which were available when the committees prepared their Foxy Focus and books. We used to get free copies because of Madam. Thank you so much, ma'am, for always being a great help, academic wise as well as personally. Thank you so much. And as for Asha, Asha is a very, very sincere, hardworking. Asha, ma'am, good evening, ma'am. Asha Jain is a very, very sincere, hardworking, and what you see is what you get. There's no hidden agenda anywhere, and that is always appreciable because we know where we stand with her. She can be very blunt when she wants to, and that is a very, very appreciable quality, Asha. I think you should have that throughout, because that's going to there's no false this thing anywhere. So that is a great thing, and you should. Any help, we are always there for you. We know that we come to every Chhattisgarh meeting when you call us. Thank you so much. And I'm seeing Shruti, always remember as Sivagami. We were co-ramp walkers in Indore, and we enjoyed a lot. It was a nice experience. And regarding the topic of both APH and PPH, I think there needs to be no hold barred. You have to learn everything about PPH and APH. And as Asha Jain said, you have to do it according to the guidance. You can't do it on your own, because maternal mortality reviews are almost like they kill you during a maternal mortality review if anything goes wrong. And you cannot save your skin if you're not up to the mark. And that's why learning through these webinars, actually COVID has brought us such great initiatives where we learn so much through such great experts. And I'm looking forward to learning from this panel. Thank you so much, Asha, for inviting me. And I'd like to welcome all the societies of Madhya Pradesh who have joined. A special welcome to Asha Bakshi ma'am, who's helped me in my first study, which I did for Foxy. I was a PI because of her help. Thank you so much for that. Thank you.
Thank you, Charmila. Asha ma'am, I kept you for the last because you said you were traveling.
Yeah.
So here's our own Asha Bakshi ma'am, who's an MS FICOG, FRCOG, and she is currently the Vice President, Foxy, West Zone, Treasurer, ITSAR, Member of Executive Committee, AICC, RCOG, West Zone, Founder, Chairperson, MP, IAGE and MP, ITSAR, Member of Advisory Committee, PCP, NDT, Indore. She's also been the Chairperson of Foxy Infertility Committee, Member of ICOG Governing Council, and past President of IOGS. She has the first ICSI, TESA, ICSI and micro TSE ICSI babies of Madhya Pradesh.
Asha, it's okay. Everyone knows me. This is Madhya Pradesh, so they know me, no problem. Please go ahead.
Welcome, ma'am. Welcome. And we would really want to hear a few words from you.
Before that, I want to acknowledge the presence of Asha. I missed you in my this thing. And Asha, it is such a pleasure to see you, because as soon as I see you, Archana Baser, all of you, even Alka, everybody, that I feel like home. And whenever there is an invitation from MP, I just can't miss to come back to my Mica and my, medical college, which I passed from Indore Medical College. So good evening, Asha, and we'll be seeing you very soon. So please go ahead with your...
So a very good evening to all of you. And Asha, thank you so much for inviting us. And I know you since long time. While I was abroad, that time also I had heard about you, that you were doing very good work in cervical cancer, if I'm not mistaken, because my cousin was in Raipur and she used to say that there is a very sincere gynecologist who is doing a lot of work in cancer cervix. So that's how I know you. And keep doing the good work, and we are really proud of you that you are one of us. Chhattisgarh is almost like Madhya Pradesh only. So another thing is seeing Mandakini madam. I really like her right from the beginning, but I developed more respect for her when she became the chairperson of ICOG, because that is the time the educational level of Obs and Gynae amongst the gynecologists really went up very high. And till now, because that now she has given a trend, this webinar and the ICOG courses, they all are doing so well. So congratulations, madam, for setting such a good trend. And Charmila, she has been a good friend. And we both did the study, mother study on ovarian reserve, which was an all India study. And I'm glad that you helped me out and we could do it. Because again, I want to do one study, but I'm not getting sincere people like you. So that's you. And I'm so happy that today it is a Mahakumbh of all Madhya Pradesh societies. And so happy to see Anita, Shruti, Shabana. I'm sure, I just let me see who all are there. See. I think Brajbala is there, Jyoti Banglowala is there. So really, it's a nice thing to see you all. And I wish you all the best. And I'm sure this webinar is going to go very well. And I wish you all the best, Asha, for your campaign also. And I hope you get whatever you want. So best wishes.
Thank you, madam. Thank you so much.
And one more thing, Asha, I take this opportunity to invite you all to my Vice President conference in Indore, which is from 20th to 22nd October. And it is going to be a very good conference. We have selected our scientific team, especially Dr. Sumitra and Dr. Manila. They have really selected very good topics, and the theme is New Age Obstetrics and Gynecology. So whatever is the latest, we have really got very good speakers who are authority on the subject. We have got faculties coming in from UK also, Dr. Sujata Gupta, Dr. Ankita Sharma, Dr. Rani Thakkar is also going to address us on the obstetric anal sphincter injuries. We have got 6 workshops, and one is on obstetric anal sphincter injury and the instrumental deliveries, and infertility, endoscopy, medico-legal workshop, ultrasound and fetal medicine workshop. So everything is very well selected with very good topics. So I request all of you to come, and please encourage your friends also to join. So thank you very much for giving me this opportunity.
Thank you, ma'am. Thank you. So thank you, Jaideep sir, Mandakini ma'am, Asha ma'am, and Charmila for your blessings and starting the webinar and giving it a tone. And thank you, Corona, for being here. And now I would like to start the panel with your permission, ma'am. Mandakini ma'am, Asha ma'am, may I start the panel now?
Sure, please go ahead.
So our expert is Dr. Jyoti Banglowala. She is caught up in an emergency and will join us later. So she has 26 years of experience. She's the chairperson-elect, Ethics and Medical Legal Committee, FOXY, Vice President, Indore Obstetric Gynec Society presently, Secretary, Indore Obstetric Gynec Society in 21-22. We all know her, a very happy-go-lucky and sincere worker. She's a treasurer of IOGS 2019-20. She's interested in ethical and medical legal aspects of obstetrics and gynae. So she has many awards. The latest one was MS Signature Awards. And may I have the next, please? Next. My co-moderator is Dr. Shabana Sultan. She's the secretary of Bhopal Obstetric Gynec Society. She has presented many papers in national conferences. She's the member of esteemed team of PPH Bundle along with Sevagram, past joint secretary Bhopal Gynec Society, past treasurer Bhopal Obstetric Gynec Society, and presently she is the secretary. She is also an executive member of MP ISAR. She has done many international projects with Harvard University and has a special interest in gynec oncology and high-risk pregnancy. She is a master trainer of cervical screening program. So welcome, Dr. Shabana, ma'am.
Thank you, ma'am. Thank you for the nice words.
Next, please. These are my panelists. Dr. Jagriti Nagar, who's the president of Sagar Obstetric Gynec Society. We'll just introduce in short. we have Dr. Anita Srivastava, ma'am, who's the president of Bhopal Obstetric Gynec Society. Dr. Manek Panse has just developed severe URI, so she may not join. She is the president of Jabalpur Gynec Society. Dr. Deepti Gupta is the secretary of Jabalpur Obstetric Gynec Society. We have Dr. Shruti Malvi, better known as Shivgami. Your act at Indore was outstanding. Then we have Dr. Ruchi Saxena, who's the secretary of Hoshangabad Society, and Dr. Alka Agrawal has expressed her inability to join. So with this, we will proceed to the panel. We have approximately 45 minutes for the panel, and we will be discussing guidelines. It is my request to all the panelists to discuss the guideline first, but it's not a ban that they cannot actually discuss their experiences. But with their experiences, they also have to discuss the guidelines. So first we go to antepartum hemorrhage guidelines. The latest guidelines that are available are the Green Top Guidelines number 63, which came in November 2011. You can imagine it's been such a long time and still we don't have newer guidelines. So as an introduction, I would like to ask my panelists, what is the incidence of antepartum hemorrhage? Any of the panelists may answer, please.
Good evening, Asha ma'am. It's
Namaskar,
nice to be
Anita
with you. I'm Dr. Anita Srivastava from Bhopal. Antepartum hemorrhage is the bleeding from the genital tract occurring after the 24th week. And it is about 3 to 5% of the pregnancies are complicated by this. It may be a placenta previa or abruptio or of a known cause or the mixed variety. But it is about 3 to 5%, I think.
Thank you. It's between 2 to 6% is the final figure. So what is the contribution of APH to maternal mortality?
Good evening, ma'am. Dr. Deepti Gupta here
Yes,
from
Dr.
Jabalpur.
Deepti. Yes.
Ma'am, the contribution of APH to maternal mortality in current scenario, I believe, has significantly decreased, though we still have a long way to go. And earlier, we used to see a lot of cases being lost to hemorrhage because of APH and PPH. But as of now, with improved surgical techniques, better availability of blood products, hemostatic agents, availability of dedicated obstetric ICU services, and intensivist and multidisciplinary approach, at least in our institute, we are definitely seeing a significant and clear decline in maternal mortality because of APH, especially if the woman is referred in time. I diagnosed and referred in time.
True.
That is very true. And you've already answered the third part of the question. And that is it possible to prevent this fraction of maternal mortality?
Yes.
You've already said that, yes, it is. Right.
Right.
So,
Madam, I like to say that we cannot prevent 100% of the deaths with it, but
agree.
we can definitely reduce the number to a great extent.
Yeah. So it is preventable to a certain extent.
Yeah.
We should anticipate and be ready for it. And then we can, yes, prevent it. Because if there are risk factors present, then we should be prepared at the outset. And that's how we can prevent the disasters later.
Very true, Dr. Shruti. So what are the risk factors for abruption? We have abruption, we have placenta previa, and then we have other genital tract causes, which were mentioned previously. So what are the risk factors?
Ma'am, for abruptio placentae, one of the commonest risk factors is hypertensive disorders of pregnancy. And another common risk factor is nutritional deficiencies, particularly folic acid deficiency. And certain drug abusers, especially cocaine, intimate partner violence, these are a couple of other factors which have been reported and documented as well.
I like to add, if the lady has previous abruption in previous pregnancy, the risk of abruption in this pregnancy increases almost to the double or the triple. Second thing, if there is first trimester bleeding in the pregnancy, the risk of abruptio placentae definitely increases. If there is IUFD, if there is some hemophilia type of thing, the presentation is non-vertex or the transverse lie or something, then the risk of placental abruption is more. Premature rupture of a membrane, intrauterine infections, any abdominal trauma, maybe it is a roadside accident, or it may be a trauma at home, violence against the pregnant woman. So these are the common risk factors, I think.
So there's a little more that it's an advanced maternal age,
Polyhydramnios.
polyhydramnios.
Or IUGR, you can add IUGR in it.
Yes. So these are the risk factors. So if we have any of these, intrauterine infection is another one.
Yes.
Where we need to be alert. And if we are alert, we will catch the risk factors and we'll be able to prevent. Dr. Shabana,
Yeah.
would you take it?
So, welcome to all the panelists. I just want to ask, are the risk factors, they are different for placenta previa, which we are getting nowadays much more cases of placenta previa?
Placenta previa is more prevalent with previous history of cesareans. So
Yes.
if there is an obvious history of previous section, first thing we should anticipate is this. And
Yes.
other things are, yes, common, but yes, previous section should ring a bell. Yes, this patient can land up into
Other
previa
risk factors,
because of the
other risk factors for
impactful-
placenta.
Yes.
Other risk factors for placenta previa are previous termination of pregnancy, maybe MTP or septic abortion, any infection, intrauterine infection, which has got damage in the endometrium. For example, any uterine scar, endometritis, manual removal of placenta, or in multiple pregnancy, twins and all, we may have, or even IVF increases. It has said that IVF increases the chance of placenta previa.
Yes, I think well covered, because nowadays we are getting much more cases of placenta previa because of the previous scar and difficult curettage cases, adherent placenta is there. So thank you panelists for that, and we move forward. I think a repetition that APH can be prevented.
Ma'am, it really cannot be
Rather, you can say, can we predict it?
Predicted to a certain extent.
Some extent only.
Some cases.
Ma'am, and as for prevention, I think, going back to all those causes, that if we look at correcting the overall maternal well-being, if we judiciously utilize our medications and uterine procedures, and looking at the primary cesareans using the Robson's criteria, so probably some of these factors can, to a certain extent, help in decreasing the ultimate, at least the previa incidence. And secondly, anticipation and prediction to a certain extent can be done based on a detailed, thorough history.
Exactly.
Yes, like we can predict
Early
preeclampsia, and it is one of the major factor for APH. We are getting so many cases, they are
Yes.
covering with severe preeclampsia as well as with abruption. So
Yes.
yes, we can predict it.
Actually,
According
the
to
guideline says that you cannot reliably predict it.
Yeah.
You can say it is probable, but you cannot predict that it is just going to happen. There's a difference. So prediction is not possible, but high risk awareness has to be there.
Yes.
Exactly.
And early reference can make a difference.
According to guideline, USG, when we done for target scan, localization of placenta should be done at that time.
So if there is a low-lying placenta, then we can identify at the time of 32 to 36 weeks, so that we can prevent for further disaster and further complications.
Even in the last trimester scan, it should be done thoroughly. What is the extent, and agar accreta and these things can be predicted, it will be a very happy thing for the gynecologist.
Agreed. So the basic thing is, what I would like to add here is that we as gynecologists should ask what we want. We just write that, fetal well-being, and then the sonologist will do only fetal well-being and send it back to you. So whatever you want, you need to actually ask the radiologist. And if you're doing it yourself, you need to keep a checklist. So can APH be prevented? Predicted, definitely no, but can it be prevented?
Not 100%.
But
To a great extent.
yes.
To a large extent, yes.
So modifiable risk factors should be modified.
Yeah.
So
We
abruption.
cannot prevent, we cannot avoid LSCS in every patient. We have to do it. So if there is a patient of previous section, there is always a risk of APH. We can just warn our patients to take care. If there is anything like bleeding or discharge, she should come to the hospital as early as possible. And from the periphery, it should be referred as early as possible. That is the only thing we can do. But we cannot prevent every case of APH, I think.
Yeah, that is true.
And patient education should be done at the very outset. That if you even a slightest spotting, you should report to the hospital. Do not just go for some injection bottle here and there.
Yeah.
So what is the association with tobacco and recreational drugs? What does tobacco cause and what do recreational drugs cause?
Recreational drugs are usually associated with abruptio.
Yes. And
And
tobacco?
Tobacco, if I'm not mistaken, was associated with a slight decrease.
Intrauterine growth retardation.
Yes, right.
Yeah.
Yes.
And indirectly by causing FGR, it will contribute to abruptio.
Yes. So, and what about the use of folic acid? This you had answered.
Yes, direct association with abruptio.
And what about the use of heparin? Does it cause APH?
No, I don't think so.
Dr. Anita?
It increases the cause. It increases the abruptio. And if we have to avoid that thing, we should avoid heparin or warfarin. We should go for enoxaparin. Even low molecular weight heparin is associated with more chances of abruptio.
Okay, suddenly I don't know where Dr. Shabana has gone. Can't find her.
I'm here. I'm audible.
Can't see you.
Yes, you are.
Yeah, now you are there. You stopped speaking, so I had to take over. Come on, go ahead.
Okay. So moving forward, we all know that the patient of APH, we are going to avoid the vaginal examination and rectal examination, as well as we have to advise the patient for avoiding the penetrative sexual intercourse. But what about cervical cerclage? What do you think? That are they going to be preventive? Are we going to advise for cervical cerclage?
No role.
According to evidence, cervical cerclage has no role.
Yeah. Even according to
New
our
studies
personal
are showing
experience.
this.
Even, yes.
Do you want to add?
No. According to the
you want to say
evidences and
something?
according to our personal experience, it has got no role in preventing APH.
And the same guideline is also saying that cervical cerclage is not having any role for in cases of placenta previa as well as any type of.
Trying to do an invasive interference of the cervix when we are scared that it might cause bleeding.
Yes, exactly. And what about the tocolytic? Because pehle zamane mein gynecologist and obstetrician, they were using tocolysis for these type of patient of placenta previas.
Ma'am, no rule
tocolytic
again.
With symptom,
can look.
If we know she is a patient of abruptio, then we should not be using tocolytics just to prolong the pregnancy. But
And
if
in
the
case of
patient
placenta previa,
and she
Ma'am,
has,
even in previa, there is no role. Placenta previa bleeding is typically classified as a causeless, recurrent, and painless bleeding.
exactly.
ma'am, if patient is asymptomatic.
According to the guidelines, there is no role. But what I personally feel, if the uterus is very irritating type of uterus is there, or if irritable uterus is there, or if she has got mild uterine contraction, then tocolytics definitely works in placenta previa. But in abruptio placenta, it has got no role.
so which tocolysis, Anita ma'am, you want to choose? What type of tocolytic agent?
I usually use isosuprene. I have
how
no
long, ma'am?
experience with
For how long?
atosiban. Atosiban का मेरा कोई experience नहीं है.
Isoxaprine I'm also using.
हाँ, I use
Aisha
it.
ma'am,
But-
आप कुछ बोल रहे थे Aisha ma'am?
I was asking for how long do you use it?
Till the
Till
uterus
48
get turns
hours.
down, 48 hours or even for 3 to 5 days, till the patient is comfortable. She has got no, usually patient complains of mild pain in abdomen. If the pain goes, if the uterine contractility decreases, then we can stop it.
Dr. Shruti?
Madam, I would love to continue it. I see no harm in continuing it till 36 weeks if I can. Oral
Ma'am,
tablets.
actually,
I
the
mean,
drug guidelines are that it is not to be used for more than 72 hours. That is the guideline.
the acute
Because
condition.
after that, the uterine muscles have an escape effect and it doesn't work.
Okay.
So that is one thing. And another thing is, if she has abruptio, what you are seeing outside is actually
Report the Asperger's case. We don't know
means
what's
if
happening.
it is placenta previa, yes, we can think of tocolysis, but not in abruptio, right? Is
Yes.
that clear?
Yes, it will cause vasodilatation and increase more of the bleeding in
Yes.
abruptio.
Agree.
Yes.
Absolutely.
Yes, and we have to choose कि जो hemodynaमिc instability है वो और ना बढ़ जाए. ऐसा tocolytic ना choose कर ले कि हमें patient की hemodynamic instability दिखने लगे. So I just want to ask then, if we are encountering with patients of APH, what are the possible complications which can be occur? I'm audible?
Yes, ma'am. Ma'am, like most obstetric conditions, the complications can usually be divided in maternal complications and fetal complications. So the maternal complications would be short-term or long-term. And the short-term complications could include acute hemorrhage and its various side effects. Long-term complications could include subinvolution, increased risk of sepsis, infection, increased, obviously there would be a likelihood of operative intervention, associated complications because of blood transfusions which may be needed, prolonged hospitalization, and for the fetal complications because of the chronic blood loss, there could be fetal hypoxia indirectly affecting, causing growth restriction. There could be increased risk for fetal infection as well. And such complications can be there.
Exactly. Now over to you, Aisha ma'am.
So is APH associated with any specific pregnancy complications and outcomes?
With
Due to APH, the patient may land up in preterm labor.
Yes.
Prematurity of the baby or the perinatal outcome will be poorer. She may land up with bleeding, and that bleeding may cause long-term morbidity and as well as mortality. You mean to say that?
Yes. So basically, domestic violence has to be kept in the back of our mind, which is quite specific for APH. And there is maternal and perinatal morbidity and mortality. When I was a student, our teachers always said a candidate of APH is a candidate for PPH.
Yes.
So all of you who are teachers, I think you're saying that to your students even now. So that is very specific, that APH is associated with PPH. And then there are, the whole massive transfusion protocol and everything. We'll discuss that in the panel on PPH. So what are the outcomes in unexplained PPH? APH, unexplained antepartum hemorrhage. What are the outcomes that we can see?
In outcomes, she may land up in preterm delivery. She may have to undergo preterm labor induction or termination of pregnancy. Her baby may be premature. Due to prematurity, the baby may be admitted to NICU. There will be a neonatal death. Unexplained APH may land up her in blood loss during labor and after labor. For that, she may need emergency LSCS, or she may has to refer to a higher center for that. Multidisciplinary approach, wherever is available, she has to be referred there. She may receive massive blood transfusions for that, and the complication of blood transfusion we all know. So,
and for the baby, the complications of prematurity, anybody would like to speak about it? Complications of prematurity in the baby.
Ma'am, because of prematurity, the baby would be prone to hypothermia, sepsis, hypoglycemia, hypocalcemic seizures, prolonged NICU admission, and associated risks, and long-term sequels like cerebral palsy or hypoxic injury, retinopathy of prematurity. There are quite a few actually.
Yeah, and the means intelligence is also less. Dr. Jagriti, want to say something?
Ma'am, chances of respiratory disease are more common with these infants, and with mothers, if there is a history of abruptio, then there is a chances of likelihood of DIC and renal complication are also associated with these.
So this is a very common question. Where should the woman presenting with APH be managed?
a place where all the facilities, multidisciplinary facilities are available. For example, there should be a senior obstetrician there. There should be a proper labor room. There should be facility of blood transfusion. There should be a physician who can handle the multi-organ, multidisciplinary action for that. Sometimes the surgeon may also be needed for that.
The anesthesiologist and pediatrician
Yes.
should also be kept in the loop.
Yes.
Pathologist the lab facilities should be available. And moreover, if she has landed into a first trimester spotting, that should ring a bell for the next all the following months. She should be constantly counseled and prepared to go to a center for her delivery where all these things are available.
Yes.
उसके हस्बैंड का सबसे पहले ब्लड ग्रुप कराना चाहिए. उन लोगों को पता नहीं होता उनका ग्रुप.
डोनर रेडी करा के रखना चाहिए.
Exactly.
Shabana ma'am.
Yes, ma'am. So I just want to ask, what is the role of clinical assessment in APH?
Ma'am, the clinical assessment is actually quite important.
Yes.
And perhaps taken for granted to a certain extent because बहुत ज़्यादा अपन diagnostics पे dependent होते जा रहे हैं. तो मतलब detailed history taking starting right from her preconception period about her nutritional status, background history, etc., her past obstetric history. Many a times small uterine interventions like DNC, etc., are skipped. मतलब patients are like, बस हाँ कभी सफाई करवाई थी, ऐसा वाला. And then her pregnancy progress throughout. And then, of course, a thorough clinical examination, including the general and the systemic examination. There should be a good stress on pallor of the patient and overall build and nutrition of the patient. The idea is also we need to understand the, compliance and the awareness of the couple, because we need to tell them and counsel them and prepare them for the complications. Sometimes we may even need to keep them in hospital for a long term duration, because probably they're not in a position to understand the implications and come back and forth for regular monitoring.
So actually we have to track where the patient stands in terms of management. कितना severity है, कैसा management चाहिए.
कितना amount का मतलब loss हो रहा है patient का. Yes, कितनी severity.
I like to add two things. One, the patient tell us about the medical termination of pregnancy. Why medical means she has taken tablets and she has not aborted completely, and she has suffered some endometritis and all. So this also causes the increased chances of APH for that patient. And second thing, those patients who are compensated for anemia. For example, the hemoglobin is not less, but the stores are exhausted. That patient will not withstand the APH properly. So that patient is more dangerous, is in more danger than other patients. So compensated anemia should also be checked for these patients.
So yes, a good clinical examination is very important, because what happens when a patient comes with hardness over the abdomen, she's come with bleeding PV. Sometimes the diagnosis may be different. हम उसे APH diagnose करके बैठ जाते हैं. कई बार ऐसा हुआ है मेडिकल कॉलेज में कि स्टूडेंट्स ने देखा और बोला कि मैडम ये तो एब्रप्शो प्लेजेंटा लग रही है, बट वो पेशेंट निकली पोस्टीरियर वॉल रप्चर. तो इट हैपेंस मेनी टाइम. So a good clinical examination is really very important. हमें diagnosis में clinical assessment powerful रखना पड़ेगा कि abruption की patient कैसे present कर रही है, and एक rupture uterus की patient कैसे present कर रही है. And कई बार it happens that abdominal pregnancy with a tender uterus, extreme tender uterus, but although उसमें bleeding नहीं थी, but tenderness extreme थी. तो ये सारे differential diagnosis में आ जाते हैं. So good clinical examination, not dependent on the diagnostic facilities, is really gives you a good clue for further management. Thank you so much. We move
They
forward.
should have their pulse and BP taken. It's the very
Good
basic
clinical
thing.
examination. Yes.
Yes.
Then, because then only you can decide what is her hemodynamic status before you do anything big. Then the abdominal palpation, you can examine by a speculum definitely. And if she has sonography reports where the placenta is not lower segment,
Then we can.
you
Then-
can do a digital examination.
Yes.
Right? Because outside maybe there is a very little blood and the vagina is full of clots. That possibility is
It
also
happens.
there. So what are the investigations that should be performed? What?
Ma'am, in this,
The routine investigations are CBP, her blood group and type, her bleeding profile, PTI, or ultrasound with the placental mapping, and according to the routine investigation, which suggests something else which is predisposing her for APH.
One question I want to ask you all. In your places, is the Klehr-Betke test available?
no, ma'am.
No. So for us, it is just theory. That
Yes.
even if you do it, it usually doesn't show up immediately. Nothing will show. So then would you give anti-D or not? If the
Yes, we
mother is
should.
RH negative, would you give anti-D?
Yes, we should.
Should give.
With
Unsensitized.
every episode of APH, even if it is minor bleeding, we have to give NTD.
Means I'm asking
But-
you all a
yeah.
practical question where I want to know, even for my own practice, how do you decide how much to give? You give just one vial or you give more? How do you decide how much are you going to give?
Sir, madam, without calculating anything, we give 300 micrograms.
Same here, madam. We are also giving 300.
Means anyone has given more than that ever?
No.
I have not.
This is a
पहले
mention in the
500
guideline.
Yes.
गाइडलाइन में 500 है मैडम, पर लेकिन हमने कभी नहीं दिया.
Yes.
Okay. Okay. So that is what I wanted somebody to bring out that is what has to be given. Even in the first trimester, it should not be less than 150. And
Yeah.
Semester we give 150.
okay. So now what are the fetal investigations you're going to do?
CTG, so regularly we do.
Madam, first the sonography, fetal heart rate recording, intermittent fetal heart rate recording, CTEG.
And
अब stabilize हो गई तो periodically we should see
The
the
growth.
ultrasound.
And assuming that she's, yes, like Shruti ma'am said, assuming that this was her first episode or she's on McAfee regime and on conservative management, I guess only then there would be a role of ongoing fetal monitoring. Otherwise, most cases of APH would be needing immediate intervention.
okay. So
And
how
we don't have fetal scalp electrode or fetal pH sampling, ma'am.
Madam, I have come across 2 patients of Vesa previa. They had mild bleeding throughout their pregnancy, but they took the pregnancy up to 36 weeks and then delivered the baby. So then in that case, we have to go for fetal monitoring regularly. Na?
Ma'am, if the vasa previa were bleeding, she would not have carried the pregnancy. She may have had vasa previa, but that vasa previa is from the lower, the umbilical cord is inserted marginally, and then it is from the edge that there is bleeding. The vasa previa, once they're ruptured, the baby is gone.
No, but spotting.
But even if there is vasa previa, the bleeding would not be from the vasa previa. The bleeding would be from the marginal placenta.
Yeah, maybe.
So should women with APH be hospitalized, and if so, for how long?
Madam, if the bleeding is very mild and the baby is healthy, and mild means just few spots are there, and the patient is a bit educated type, and as we advise her to take rest at home, so she can be sent home if there is no bleeding when she is present in the OPD. But if there is mild bleeding, she should be hospitalized till she is stabilized. And if there is more than that, if the patient is not stabilized in next 2 to 3 days, then the pregnancy termination has to be done.
Means I want to ask you something that I want to learn myself. How do you exclude abruptio? Means because outside the spotting is a few drops, but how do you exclude abruptio?
Madam, in a
tricky situation, madam, especially early grades of abruptio, and especially if it is a concealed types.
Dr. Shruti, you wanted to say something?
We rely mostly on our radiologists for our sonographies. कि भैया आप देख लो पूरे प्लेसेंटा को अच्छे से देख लो, डॉपलर करके देख लो. This is what we actually do and keep the patient in hospital.
Madam, abruptio में usually pain मिलता है, and the uterus जो है उसमें contractions मिलते हैं, मतलब एक tonic contraction type की feeling आती है उसमें. But अगर वो absent है and bleeding नहीं है और radiologically, sonographically अंदर कोई blood clot नहीं है, तो observe करते हैं and after 6 to 8 hours sonography repeat करते हैं. अगर अंदर फिर भी कोई collection नहीं है, तो we say there is no abruptio.
अब आप लोगों के लिए एक बुरी खबर देती हूँ मैं. वो बुरी खबर ये है कि अल्ट्रासाउंड कैनॉट मेक आउट.
I know.
Ultrasound cannot make out if there is a partial separation of the
fundal height is
placenta.
rising.
माइल्ड एब्रप्शन में फंडल हाइट कैसे राइज होगी जब लेते?
मैडम फंडल राइट जब हाइट राइज करेगी तब सोनोग्राफी के लिए पकड़ना आता है.
लेट अस बी वेरी ट्रूथफुल. हम में से कितने लोग फंडल हाइट को मेजर करते टेप से?
Nobody does.
So you don't measure it and ultrasound doesn't make out. तो फिर अनीता मैम ने जो बोला ना कि irritable uterus है, that
Irritable.
we need to actually pay attention on that.
Yes.
Yeah.
That is very important because ultrasound तभी बताएगा जब clot is organized, and because it is organized, there is no flow across. Otherwise, even when you do a Doppler, with the movement even of breath, that blood is moving and it doesn't show as a separated placenta.
I agree.
So again, we come back to the fact that the clinical sense is most important. All of us need to work on that. Now,
Madam, I would like to share a case of mine. She was 6.5 months pregnant, and she was diagnosed as a case of APH by some other doctor, and she came to my hospital. After all the investigation, there was no previa, there was no sign of abruptio. I just did a per speculum examination. There was this about 3-inch long polyp from the cervix, and that polyp was intermittently bleeding. And for that, she was diagnosed as a case of APH, and termination of pregnancy was advised to her. So proper clinical examination is very important, I think.
very true, very true. Now, a woman has come to you presenting with APH. She's 32 weeks. Would you give her corticosteroids? Yes or no?
Yes.
Yes, ma'am.
Yes.
So this is unequivocal. We are going to give steroid.
Yeah.
Are you going to give her tocolytics? We've already said yes,
Already discussed.
but not for more than 48 hours. Once she has bleeding, will you alter her care? Or will it be the usual care?
Of course, it will be a high-risk patient and the care will increase, the vigilance will increase, the management will be different. More targeted and more focused antenatal care and more preparedness for the delivery.
Unless it is a polyp which has been removed.
Unless it is a polyp, yes, exactly.
So when I was doing my PG, I had a patient who was bleeding and we put in a speculum and it was a cauliflower growth. Her entire cervix, upper 1/3 of vagina was a tumor.
Yeah.
So we had to do a classical cesarean and deliver that baby and then send her for radiation. So you actually coming back to the fact that as gynecologists, we need to put in that speculum.
We do, ma'am.
Yes.
Yes.
So when are you going to deliver her and what would be the mode of delivery in a woman of APH?
Ma'am, the mode of delivery would also depend whether it is placenta previa or abruptio, the Bishop score, and the previous obstetric history, especially if there is a uterine scar, 1 or 2 or whatever. So if she's a case of previous 1 cesarean section, for example, with placenta previa, then I would like to deliver her between 36-37 weeks and not prolong her for very long time. And for abruptio, the management would depend on the Bishop score. If the Bishop's is favorable, then we can give her a trial of vaginal delivery
And the
also
position of the placenta.
position of the placenta and the severity of the abruptio.
Okay. Anybody wants to add anything? Dr. Shruti?
Madam, the Bishop score as well as the condition of the baby is very important. If
Yes.
the baby is a bit compromised, we have to go for immediate section. But if the baby is okay and the bleeding is not very much, that is between very minimal to moderate bleeding, then ARM can be done and the patient can be put up for vaginal delivery in abruptio.
So now we have only 10 more minutes, so we need to go really fast. What intrapartum fetal monitoring should be employed in a woman with APH?
Continuous monitoring should be done.
And
In all patients, did we do continuous electronic fetal height monitoring or the scenario is different in some cases?
No. In low resource settings, it is not possible to offer them continuous electronic fetal monitoring, and then we have to resort to higher frequency clinical monitoring.
you know, there is a paper.
Minor APH cases.
There is a paper on the efficacy of intermittent, what we used to do by Doppler or Stetho and
Yes,
the
ma'am.
continuous electronic monitoring.
Similar of.
And the results are really comparable because you have a CTG and nobody is actually looking at it. But
Yes.
when you're doing a clinical thing, somebody is always looking at it.
Yes.
Yeah.
So, Dr. Shabana?
Yeah.
I love
So
because
which anesthesia usually we choose? I mean, our anesthetists choose.
Ma'am, in our experience, most of the times they prefer general anesthesia.
I mean, if we
Major
if
cases of
the
obstetric
patient is
hemorrhage, I
stable,
think.
spinal can be given.
Yes, stable
And
patients
we
usually
prefer
they choose
spinal.
spinal.
Come on, quick. Spinal
Spinal
or
If the patient is stable, spinal.
spinal is
If the
mostly
patient is stable, spinal. If the baby or the mother is compromised, then GA should, so that the work can be done fast and the patient can be managed properly.
we should go for general anesthesia. If you are thinking ki, we might land up into an ID, so better go for GA and take out the baby live rather than wait and
Yeah.
okay. So how would you manage the third stage?
active management.
Active management.
Early cord clamping and leaving the long cord, which I read it, I loved it. You catheterization के लिए लंबा cord बच्चे के पास छोड़ दो and take out early cord clamping.
Ready for the PPH tray. I mean, ready for the managing PPH also.
Yes,
Yeah.
sir. Yes.
Oxytocin, carbetocin, methergin, carboprost, what are you going to give?
We are not worried about the hypertension, then all are good. Centos,
Yes.
oxytocin, ergometrin, they are very good.
Okay.
I think we have covered this, ma'am, and ready.
So if there is massive APH, how are you going to manage it? And who's included in the team?
Ma'am, she has to be triaged as one of the most important cases. We have to shout for help, ask for the senior most people available. Anesthetist has to be involved. Blood bank has to be notified. The entire readiness of the entire drill, mock drills should be conducted, and it has to be a multidisciplinary approach.
The IC management, Deepti?
Ji, ma'am.
And as Dr. Mandakini said, if she has to be sent somewhere, then somebody has to go with her, arranging everything.
Yes.
Yes.
So if she is presenting with an APH and develops a coagulopathy, now what? Now what?
Ma'am, this is a common picture, especially with massive abruptio, the grade 4 who present with intrauterine demise and tonic uteri. And in such patients, it is difficult to assess the amount of intrauterine bleeding. So it is always better again to withdraw samples. Screen and cross match is the protocol which should be followed. And a fresh frozen plasma transfusion should always be considered for these patients, as because of the release of tissue thromboplastin, consumptive coagulopathy in these patients is quite common.
Okay, and what about cryoprecipitate?
About cryoprecipitate, madam, केवल फैक्टर 8 की डेफिशिएंसी के लिए बेटर है, बट लेकिन इसमें फ्रेश फ्रोजन प्लाज्मा के अलावा प्लेटलेट कंसंट्रेट दे सकते हैं, about 4 unit of FFP followed by 10 unit of platelet concentrate, and according to the blood loss, the packed cells can be replaced.
Ma'am, the guideline is that you start with 4 units of FFP and 10 units of cryoprecipitate, which is easily available, while you get the results, and then according to the deficiency, you're going to give whatever is required. If she's already taking anticoagulants, she's on Lonopin, what are you going to do?
Should stop.
You stop it.
You should stop.
For how long? She is on anticoagulant. She has started bleeding. You stop it. Are you going to restart it, or you're going to let it remain stopped?
It has to be restarted because due to the indication, if she is taking anticoagulant for the cardiac disease, so we have to restart it. For thromboprophylaxis also we have to restart it, but unless and until the patient is stabilized, the bleeding stops, or the bleeding is under control, then up to that place we have to stop the anticoagulants, whatever she is taking.
Okay. Now, who manages the neonate?
neonatologist.
Okay. Now, if there is major APH, abruption and vasa previa, what happens?
Both are compromised. Baby is also compromised. We have to inform the pediatrician in advance that the baby may be limp or suffering from some kind of hypoxia. He has to manage it properly.
Okay.
Or
Dr.
anesthesia
Shruti
team
has
should
also answered this, that you leave a long cord. And if it is placenta previa? If it is,
then also same.
yeah, but it should be operated by a senior obstetrician.
Yeah.
You
Yes.
can't leave it to the
Have
residents,
to go
right?
through the placenta, yes.
24 to 26 weeks pregnancy with APH. How are you going to manage it?
Ma'am, APH is one condition where it is mainly the mother who is at risk. So considering the maternal morbidity and mortality, irrespective of period of gestation, the chances of operative intervention are very high.
Somebody has APH. What are the postnatal issues that can happen? Baby is born, but what next? What complications can occur?
Patient may land up in PPH. Patient may have chronic anemia later on. The uterus may be scarred. So next pregnancy, the chances of abruption and the chances of placenta previa is more. And the recovery is a bit delayed. She may have a neonate loss. So the psychological aspect is also there.
Can somebody tell me what is debriefing?
Debriefing is something like that. What we did, we have to debrief it. Like हमने कोई केस मैनेज करा, उसके बाद हमें उसे debrief करना चाहिए कि हमने एक्चुअली में क्या स्टेप्स थे, कुछ मिस तो नहीं हुई. वो that is actually called debriefing of a clinical.
Actually, debriefing technically in medical legal language is when you're getting everybody together and sitting and analyzing.
Yes.
Okay. And then
we pick the points.
No, but here debriefing is when you are talking to the patient's family
or addressing
the patient.
Exactly.
And clinical incident reporting is when you're doing it amongst yourselves. So that is the difference. You need to talk to the patient and relatives also. That is debriefing, where you are not going to give all the information. Means, let us be very truthful. We are not giving every information. In clinical incident, we are going to actually analyze it.
All correct. Yes.
So what is the role of obstetric skill drills to improve management of APH?
A lot. Because every step has to be managed properly. These drills help a lot.
Team is vital.
All the team members should know who are there in the team. When the team is called, they should be there immediately. So that is how these drills help.
And their roles should be defined to a certain extent with reference to, arranging the consumables, recording.
करना, blood के लिए कैसे बुलाना, कौन note down करेगा, कौन report लेके जाएगा, कौन samples लेके आएगा, who will talk to the attendants. So many things have to be done simultaneously. So that has to be defined step by step.
So in an institute, that's fine. But APH or PPH can occur in a single doctor clinic as well. So what are your suggestions for drill in that place? Because loose talk बहुत होता है ना, आपस में भी होता है, patient के relative से भी हो जाता है. So what are your suggestions for that? Single doctor
drill single obstetrician के लिए भी बहुत important है, क्योंकि अगर step by step, if she knows what has to be done, so then she can manage it properly without giving any muscle की panic हो गया या हमसे नहीं बना.
की बात करते हैं तो अगर एक सिंगल डॉक्टर है तो सिस्टर कैन बी a team member for her. A sister can be a team member for her.
drill करें,
just to support.
drill करें. हमारे पास ये resources है, हम कैसे पेशेंट को स्टेबलाइज करके फिर रेफर करेंगे. यदि रेफर करेंगे, जहां रेफर करेंगे उनमें किसको कांटेक्ट करके वहां तैयारी क्या करवा के रखेंगे, एम्बुलेंस कहाँ से आएगी, ब्लड कहाँ से आएगा, स्टेबलाइज कैसे करेंगे, कौन कौन हमारे पास रहेगा. These things should be prepared and drilled in a
Proper referral protocols to be followed.
Nephrologist and
So
anesthetist
the
should also
basic thing
play
is the
these
guidelines don't change. Whether you are in an institute or you are in a private clinic, the guidelines remain the same. You have to have obstetric drills. You need to define roles. And these are the different topics that we need to audit. What happens when you give steroids? What are you going to give anti-D or not? What is the percentage of women who are getting APH, recurrent APH? How the third stage was managed, and training of the multidisciplinary team. So thank you. Thanks a lot.
Thank you, ma'am.
And I want
Thank
all
you,
of
madam.
you around.
It was
so
very
that-
nice discussion.
Thank you, ma'am.
totally.
Thank you. Now, anybody wants to add anything to the discussion? Jyoti, you've been listening. So
Excellent discussion, ma'am. Excellent.
anything anybody wants to add before we start the next?
ज्योति करंदे मैम से मेरे को एक रिक्वेस्ट करना है. मैम
जी,
एक पुराने पिछले वेबिनार में आपने
हाँ।
क्वांटिफिकेशन ऑफ ब्लड लॉस को बहुत सुंदर से बताया था. 100 आप भरेगा तो इतना करके बहुत.
But that is not वो बताया होगा, but that is not to be used.
That is
Most
not
of the time.
standardized.
Yes,
not
that is most of the
standardized.
time it underestimates blood loss. You should assess clinically ongoing hemorrhage and vital parameters. So मैं भेज दूंगी, but that is not recommended by any authority. That
Thank
is
you,
just
Dr.
for
Shabana.
Yes, ma'am. But I think in case of postpartum hemorrhage, that rough assessment is also useful.
yes, rough assessment. It will
But
give,
rough
it will alert
assessment
you.
Because
बहुत हो रहा है.
once we are in a habit of quantifying blood loss, that is very important. Because quantification ना करें और vitals deteriorate होने का wait करें, it is not justified.
Absolutely.
I mean, a minor PPH can become a major, sometime a hidden PPH or APH also, same happens. So it was very nice discussion. I think thank to all the panelists for wonderful slides by Dr. Aisha ma'am and a fruitful discussion by all the panelists. Thank you so much. Thank you, Aisha ma'am, for giving the opportunity. Thank you all the panelists, Dr. Anita Srivastava madam, Dr. Shruti, Deepti, and
Shabana
Jyoti.
ma'am, आपको भागना नहीं है अभी इसमें भी.
नहीं, I am here. Ma'am, PPH is my favorite topic. I did lots of many projects. I am here only with you.
So we are going to start the next panel, which is on
Yes, ma'am.
PPH. And I'm the moderator and co-moderator is Dr. Sadhna Mehta. Ma'am, आप कहाँ हो?
Yeah, good
He's
evening.
there.
myself.
He's there.
Yeah, yeah.
Namaste,
Asha
namaste.
ma'am, namaskar. I am here only.
Yes. So हमने जितना cover कर लिया, we will not repeat that. And we will start now. Madam is the incoming president of Indore Obstetric Gynec Society. These are our panelists. Dr. Brajbala Tiwari, President Indore, Dr. Jyoti Karande, Secretary Indore, Dr. Vrinda Joshi, President Gwalior Obstetric Gynec Society, Dr. Renu Jain, Secretary Gwalior, Dr. Rupali Maheshwari, Secretary Ujjain, Dr. Shweta Kaul, incoming Secretary of Indore, and Dr. Anuradha Pancholi, who is the Treasurer of Ujjain Society. Welcome all of you. Because we are all known to each other, I'm not really expanding this because I sort of have that in me that we should finish on time. You know, किसी का extra time waste नहीं होना चाहिए. So let us take it forward from here. We are going to discuss two different guidelines. One is the Green Top guidelines, that is of December 2016, and then the ACOG guidelines, which have come later. So postpartum hemorrhage is the leading cause of maternal mortality worldwide. The prevalence rate is approximately 6%, and out of that, 50% is due to atonic PPH. According to WHO 2014, in India, 45,000 maternal deaths take place annually, and 20 to 60% are due to postpartum hemorrhage. So when we are talking of prediction and prevention of PPH, what are the risk factors for developing PPH and how can they be minimized? Dear panelists,
Good evening, ma'am.
good evening.
Myself, Dr. Renu Jain, Dr. Renu Jain, Secretary from Gwalior OBGYN Society. Ma'am, there are many risk factors which all clinicians should know about them, and they can be present in antenatal period, or they may have present during intranatal period, intrapartum period. So during antenatal period, the risk factors may be like placenta previa, placenta accreta, previous for any coagulation disorder, patient is having some coagulation disorder or having thrombocytopenia. And during intrapartum, like the baby is microsomic more than 4 kg, baby weight is more than 4 kg, the patient is multipara, and there is prolonged use of oxytocin for labor augmentation, and prolonged second stage of the labor is another risk factor for development of PPH. So we all should take care of these risk factors, and we should
twin pregnancy, prolonged first stage, prolonged second stage, if an instrumental delivery is been done, if she has preeclampsia, or if she is undergoing any procedure under general anesthesia, that also becomes a risk factor for PPH.
So when you're talking of minimizing risk, what do you think about anemia?
It should be treated antenatally, and oral iron therapy should be given. Now it's we give universal oral iron therapy to all women. If she's near term and she's not tolerating oral iron, then IV iron. And if IV iron is also, she's very near term, then maybe blood transfusion. But by any means, before she goes into labor, her anemia should be corrected.
What
and
about sickle cell patients or thalassemia patients?
Then they should be delivered in a proper center. I mean, their medical condition should be optimized under a multidisciplinary care team, and they should not be delivered in an isolated center. It should be delivered where all facilities, even ICU care is available for them. And blood bank facilities, ICU care, everything should be available when such patients, they are high risk pregnancy, so they should be receiving proper care.
So what is your opinion about uterine massage? Reducing the blood loss at delivery. So 3 things: uterine massage, uterotonics, and tranexamic acids. Which of these would you use?
Uterotonics, oxytocin, routinely for prevention of PPH. And tranexamic acid I use for all cesarean sections. For normal deliveries, oxytocin is the first drug of choice for prevention of PPH.
What about uterine massage? Somebody, she's delivered normally, sab theek hai, and suddenly she starts bleeding. So would you give uterine massage, yes or no?
Yes, ma'am.
Yes, ma'am. Yes. Bundle massage is beneficial.
If the cause is atonic uterus, then we will do the uterine massage. If the cause is atonicity.
The guideline says that uterine massage is of no benefit.
That is prophylaxis, but you said it's just started bleeding. So then you have
the treatment of atonic uterus.
You'll give massage. Okay.
Yes.
While other things are getting ready.
Yeah.
Another method of minimizing risk. So what are the procedures that you're going to use?
Uterotonics. First, we will get the uterotonic injection, oxytocin 10 international units, IM/IV, and then we will not do early cord clamping. This I want to highlight here, that there is early cord clamping is not recommended nowadays. We should do cord clamp at 1 to 3 minutes only, not before 1 minute. And
if this is preceded by APH, then if this is preceded by APH, means your woman has had APH. Now you're delivering her.
Yes, ma'am.
Would you still not do early cord clamping?
It depends on the condition of the baby, madam, at the time of delivery. If newborn needs immediate resuscitation, then we have to do early cord clamping. Otherwise, if the baby cries immediately, there is no need of early cord clamping, and we should do essential newborn care only.
Okay. So, Sadhna ma'am?
Yes, ma'am. So next is Dr. Jyoti. How should PPH be managed in such situations?
So, management of PPH will require simultaneously, we have to assess the condition, we have to start resuscitation, we have to call for help. And so medical management, everything should go hand in hand, not that just we are waiting for one thing and not doing. So immediately call for help, call another senior or your same cadre person, call a senior nurse or staff, alert the OT, alert the blood bank, put 2 IV cannula, start crystallites, start uterine contraction like rub up or massage, catheterize the patient, and then take blood, send it for CBC and coagulation profile, and ask the blood bank to be ready. If required, then we may ask for 4 units of blood immediately. So this is the first line management. And then uterotonics, we spoke about it. If 10 units of oxytocin, which we have already given to the patient, and if she has not responded, then again you can give 5 units instant IV, followed by a drip with 40 units.
Jyoti will be discussing the massive transfusion protocol later.
Okay.
Okay. One
so
thing
it will be a
I forgot to
multidisciplinary
say
approach.
Is that communication with the woman and family is very important.
Very important. Yes, ma'am.
And
And we have to
secondly,
examine the patient to know the cause of the PPH, whether it is a traumatic PPH or atonic PPH. We have to explore the cervix, vagina also. We should explore, madam.
and
Simultaneously,
you should also explore the
traumatic and
placenta if some
traumatic.
pieces are remaining inside.
Yes,
So
ma'am.
that also should be seen properly. And if any injury is there inside, maybe some lateral tears or cervical tears, that should be taken care of. And if atonic PPH is there, you can also add tranexamic acid. That also works very well. And along with that, you can also try with carbages. And by the same time, investigations and see the patient's condition every 10 to 15 minutes, check for pulse, BP, respiration, SpO2, everything you should be monitoring, and you should call up for help for the senior persons. Assistance.
There is a minor PPH. If there is a minor PPH, Vrinda ma'am, would you like to take this?
Yes, before that, I wanted to say something about the earlier discussion that when there is PPH, Dr. Renu very correctly suggested that once the preliminary things of wearing everybody and then putting in the cannula and then starting crystalloids, everything is done, then we have to find out the cause. Now, this is one very important point where the proper lighting, proper positioning of the patient and presence of assistant is very essential to identify if there is any trauma in the entire birth canal. Because generally, when the patient is delivering, like it was discussed earlier as well, that she might have delivered in a place where there is only one doctor and there might be only one helper. Even big hospitals at times, it is the same situation. So this is a very, very important message which should be spread wide and forward, that good amount of light, proper positioning of the patient, and availability of at least one assistant for proper examination of the patient to rule out the atonic you are dealing with as it is, starting with oxytocin and arranging for blood and crystalloids and everything that is taken care of. But traumatic is one thing which is taking. In our hospital, we see it is almost 40% of patients are because of traumatic PPH. They go into shock. So that is very important to be underlined. Yes, regarding measures for minor PPH means where the blood loss is without any clinical findings, then of course that same person can manage. Yes. This is in the situations where the deliveries are being conducted at PHCs or conducted by the LHVs and similar there. There, the intravenous access, they should immediately manage. They should do venipuncture, group band screening, full blood count, coagulation screen. That all should be sent because all these things has not been done for this patient earlier. Otherwise, in a big hospital, like in a medical college setting, we expect that all these have already been there with the patient and the patient has come to us with all the reports. But yes, in a smaller setting, now is the time that if it has not been available, it should be given, and the vitals should be recorded. And besides the pulse, respiration, and blood pressure, we must add the urine out. This is the fifth vital we now say. Besides the pulse, respiration, temperature, and blood pressure, fifth is the urine output, and one should have a keen eye. An obstetrician should have a keen eye over the urine output. Even the smallest amount of urine in the catheter, means the tubing, should be getting our attention. That is what I would like to say.
One thing we have to remember, normally our sisters will put cannula which is more than 20 number. So in an obstetric setup, we should insist that whenever we are putting a cannula, it should be at least green if higher number is not available, because then blood will not go through that cannula, and then again we have to put another venipuncture and again one more cannula. Even crystalloid will go very slowly. So if you are suspecting, preparing for PPH, any high risk factor, put green cannula at least for that patient.
Sadhana, ma'am.
Next question is, how will you manage a major PPH if the patient's cardiovascular instability is there, BP is falling, and pulse rate is more, and the shock index, like what is the normal shock index, and beyond which you should be very much alert, and where you should take immediate resuscitative measures?
So shock index is a very sensitive marker for hemodynamic instability. Normally, it is calculated by heart rate and systolic blood pressure, which we do for every patient. So just it is very simple to put this formula. Normally, 0.7 to 0.9. Maximum is 0.9 for a pregnant patient. For a non-pregnant patient, 0.7 is enough. So if it crosses 0.9, you have to be very alert, because now this patient is going into a major PPH. And this is also a very good criteria for triaging. If it is going beyond 1, our patient may need ICU care, she may need massive transfusion. So it is an indicator that this patient is deteriorating. Alert everyone, tell the relatives also that this is the situation, alert the ICU, blood bank, everything. And we should also know that now this patient is critical. So put level 4 management for this patient. If it goes beyond 1.3 and all, then it's a very poor prognosis for patient. Very means hypoxia has taken up. So before that, we have to manage the patient. Do whatever we can. It should not deteriorate.
So, what way do you manage the blood transfusion? Like how many PRP, how many FFP, and how many single donor platelets you give them? What way do you design it? Jyoti?
So, this is, we are speaking about major PPH, like means the ongoing hemorrhage and patient's condition is deteriorating. So that will be a massive transfusion, like if we are suspecting, then at least for first 4 units of RBC, ask immediately for that and send the sample for coagulation profile, including fibrinogen. If the result of the coagulation profile is not available, then after 4 units of RBCs, give 4 units of FFP. And if the results come and the PT and APTT has raised more than 1.5 times, then we may require 12 to 15 microgram per ml of FFP or more. And if ongoing hemorrhage is going on, still the reports are not available, then after 4 units of RBC and 4 FFP and fibrinogen is falling less than 2, give 2 pools of cryoprecipitate and 1 unit of platelet transfusion. So the aim should be to keep platelets more than 50 and APTT less than 1.5. So till that you keep on repeating this 4-4-1-2, 4-4-1-2 depending on result. And then if this is the situation, we have to call in experts, intensivists, anesthetists, hematologists. They all will help us to manage these patients. We cannot decide everything on our own, but this is the criteria for major hemorrhage.
If the level is
less than 2,
you have to add cryoprecipitate also.
Actually, I am Dr. Vrinda Joshi. I would like to add, and
then you have to add cryoprecipitate also, and depending on the levels,
that's what I am saying, because it has been discussed many a times with the critical care.
What conditions do you use?
Ma'am, she's answering. Dr. Joshi is saying something.
No, I was saying that if availability is there of cryoprecipitate as well as fresh frozen plasma, it is better to choose cryoprecipitate as the first line, because fresh frozen plasma is associated with more number of TRALI, that is transfusion associated respiratory injury, respiratory tract injury, that has been seen most commonly with FFPs. That is why our anesthetic.
So only 4 units with 4 RBs. 4 units you have to give, because other clotting factors are not given by cryoprecipitate. It will only give maximum fibrinogen. So for other clotting factors, we
Any
need
problem
to
in
give
signals? I'm not able to hear.
It's clear, ma'am.
So is there a role for recombinant factor 7A when your lady is bleeding?
Madam, it should not be as a first line management. And I think alone obstetrician, as obstetrician, we should not take the decision of giving factor 8A, 7A. It intensivist and hematologist, if they feel that everything has been done and still the patient is bleeding and this would be of help, then under their guidance, we can give it. It is not contraindicated, but it is not a first line or second line management drug. It is mostly under trials and it has its own problems also. It is very costly also. It may not be available everywhere, but it can be given under their guidance.
So you have all described very well the monitoring and investigation of major PPH, right? Means nothing of this list remains. I've just shown this so that this is part of the guideline, so that if anybody wants to take a picture, they can take. What is Muse chart?
That is modified early obstetric warning score. So it is a chart which records all the vital parameters. And then if 2 deteriorate, it becomes orange and then red. So when it becomes orange, the sister has to alert us. If it becomes red, then it's an alarming sign. So again, the multidisciplinary team has to come in action. It's a very good system to monitor the patient, but it is common for all critical patients. So when to shift the patient to HDU care, when to put her in ICU, when to ask an alarm. A person who is monitoring the patient, it is very good parameter.
What is the role of anesthetist for managing PPH?
Madam, anesthetists have a major role in management of major PPH, because if patient has to be made hemodynamically stable, and if we need to put a central line, then again anesthetist is required. If we want to go for an intervention, exploration, or any operative procedure, again the anesthetist has to be present. So once the anesthetist comes in, at least fluid management and management of pain and central line and all that can be taken care of by the anesthetist, so that we can concentrate more on obstetric care.
So
a senior anesthetist should be called early as soon as PPH sets in.
So what methods should be employed to arrest the bleeding?
All the methods.
Whatever you can do. And what pharmacological and mechanical strategies? This we will discuss with the ACOG guidelines. What are the surgical methods available? And one question to all the experts here. Would you intervene early or late?
Early. Ma'am, it is said that you give carboprost, first dose, second dose, third dose. If patient has not responded in 3 doses, that means half an hour is already gone. Then it's time that you shift the patient to OT and go for second line management, like introducing a uterine tamponade. And of course, if it is a traumatic, then we will handle it immediately. But if you are not more than that, if 3 doses patient has not responded, if the uterus is relaxed, go for surgical intervention, shift the patient.
Dr. Anuradha, you're very quiet. Dr. Anuradha.
I'm sorry, ma'am. Actually, I'm driving, ma'am. So just to avoid the traffic noise, I've kept it.
All right.
Okay. I'm listening to you, and if there is anything I can add on, I'll definitely do. Thank you.
Okay. So, how is secondary PPH managed?
Secondary PPH is mainly due to either retained products or due to infection. So we have to manage depending on the cause. Rule out retained products by ultrasound and do a microbiology for infection, start antibiotics or evacuate depending. Mostly these are the causes.
Dr.
For
Renu, you
secondary
want to add something?
Yeah, I want to add, it can be,
Yeah.
sometimes it can be due to incomplete involution of the placental side. If the placenta is really low, most of the time the patient doesn't bleed on the same time, and lately she present like that. So in the rare scenario, I have seen that patient came with the secondary PPH and the placental side was bleeding, so the stitches on the placental side was to be taken there. So this is a rare sign, and I have witnessed it, just wanted to mention.
Thank you. Thank you, Dr. Anuradha. So, training and preparation. What measures can be taken to ensure optimal management of PPH? This is just the summary. Dr. Renu?
Yes, ma'am.
Yeah.
Ma'am, every hospital should have a definitive protocol for the management of these emergencies, like what steps should be taken first, then next. Every step should be known to each and every person of that maternity unit, like in the PDs or of medical officers posted in labor room. They should know what they should start doing first, then what should be the next step. And there should be training in the department also for the whole staff also, like they in that training the nursing officers should also be there, so that they should also know that their roles in such emergency situations, ma'am.
What do you think about rehearsals? Should we have rehearsals?
Yes, ma'am.
Ma'am, every person's role is very important. Even the lift man, the lift door should be open if you have to rush the patient. The corridor should be empty for if you have to rush the patient. Even small person, a security person, the lift person, the fire person, lab person, OT person, everybody has to know their role. So unless we do the drill, they will not know what to do when the alarm is raised of hemorrhage. So this is very important. Training and rehearsal is very important.
And one more question. How often should the rehearsal be held? If you want to do it weekly, monthly, once in 3 months, what's your experience?
At least once in 3 months, and whenever a new
months.
staff arrive, then we have to rehearse it with them.
Once in 3 months.
So this we've discussed. Documentation is extremely important.
Yeah.
Debriefing has to be done. Then what are the targets that we want to achieve with transfusion?
So hemoglobin
of at least at 8.
Yes, Dr. Anuradha, proceed.
Hemoglobin of 8 platelet count should be more than 75,000 per nanoliter, and microliter, and the fibrinogen at least more than 2, and what else?
PT prothrombin.
Yeah, APTT and PT, at least it should be less than 1.5 than the control.
Okay, so these are the targets that we want to achieve, and we use everyone. So now the most common cause of primary PPH is atony. Initial management has to be to stimulate uterine contractions. So now, would you go one by one? Your patient has started bleeding. What are you going to do? She has just started.
As we have mentioned in profile access, I personally prefer doing fundal massage. So the fundal massage followed by emptying the bladder and then giving the uterotonics. Already we have given the oxytocin 10 IU/IM at the time of birth. Then we can repeat oxytocin 5 international unit IV or IM. Even if didn't respond, then we can start methargin if the patient is not hypertensive, then carboprost. And as madam has discussed, we can repeat it every 15 minutes, and even we can give maximum 8 dosage, but we won't wait for the 8 dosage to get completed, and within half an hour we have to see the response and shift her immediately if she will not respond.
Okay, so here it's there again, the simple mechanical and physiological measure of rubbing the uterus and emptying the bladder represent first line management, but there are no published studies. So I think that is work for us where we can join together and make it. And nevertheless, professional consensus supports their continued use. So it's not that it's not effective, it's just that we don't know because it's not published. There's no proof. So these are the risk factors associated with the risk of PPH. These are already spoken about. Here it's also perineal laceration is written 2.4 times. We've discussed this, how much to give, what to give. Now we come to the ACOG guidelines. Sadhna ma'am, aap lenge?
Yes, yes. So the ACOG guideline, it says that there are safe obstetric bundle development has been done by ACOG, and this delineates the standard of care and this decreases the reliance on memory and emphasize the patient's safety and reduction in redundant efforts. So next slide, please.
Readiness, recognition, response, and reporting.
Yeah.
So what are the components of obstetric bundle?
The components of obstetric bundle are the PowerPoint slide decks, visual aid posters, checklist, algorithms, risk assessment tables, medication dosing tables, and debrief forms. So you have to check everything, and you can remember the things by a set of programs, and accordingly you can act.
Renu ma'am, what are the key elements of the bundle?
First is readiness. Every maternity unit should be ready to deal this postpartum hemorrhage, which may happen anytime in the labor room or in OT. So every obstetrician should be ready to deal with this disaster. So for that, availability of medications to treat PPH should be always be there, and blood bank should always be ready to provide a sufficient amount of blood and blood products. And as earlier told, that posters and protocols for these balloon tamponade or to apply V-Lynch stitches, everything should be there at the site of the where patients are there. And second is recognition. Like as before, we have discussed the assessment of the risk factors. So we have to be very much careful if any of the risk factor for the development of PPH is there. So we have to take care of that. And third is the response. Response means as soon as PPH develops, then we have to get alert, and we should start the management of that thing as early as possible, and to inform the patient's relatives and the other staff of the hospital. Then fourth thing is reporting. Reporting means we have to audit all the patients of postpartum, all the cases of severe postpartum hemorrhage. We have to discuss in that what is the outcome in that condition and how we manage the patient, and if there anything which we have to improve in our management, that should be discussed in that reporting. Thank you, ma'am.
Next one. So risk assessment prenatally, you have to assess the patient, each and every patient. You have to judge the patient's condition, and if any risk factors are there, then such patient should be delivered in a hospital where all such facilities are there to deal with the situation. So what are the risk factors, Renu ma'am?
Risk factors in the prenatal period are suspected placenta.
Risk factors during pregnancy.
During pregnancy is like if the patient is having this polyhydramnios, macrosomic baby, BMI is more than 50, and she is having any coagulation disorder, thrombocytopenia.
And
trial and surgery, like myomectomy, classical cesarean section.
Any previous cesarean section that also poses a risk to the to PPH in this pregnancy also. And there can be rupture of uterus in the next pregnancy, and there can be maternal anemia, infection, prolonged labor, or infections during labor chorioamnionitis, or rupture of membranes, premature rupture of membranes. All these conditions can predispose the patient for PPH.
Vrinda ma'am.
Then how you manage?
Ma'am, what
Placenta
percentage of your placenta accreta are diagnosed before they occur? Means before delivery?
We can say only 40%. Yes.
Dr.
Because we have made it a dictum in our hospital in any case which comes to us as a case of previous cesarean section, even previous one cesarean section. And there is the placenta is lying anterior, and on palpation we find that the head is still floating. Then it is a dictum in our hospital to consider that this may come out as placenta accreta. It is so common now, that is one. And even after sonography, a detailed sonography, it may be missed, because in an emergency setting we don't expect that the sonography may be done by a very senior consultant. That is one. And even senior consultants find at times difficult to differentiate. MRI could be a possibility where the previous 2 cesarean section, previous 3 cesarean section patients, where we have placenta anterior, then we get the MRI done where there may be T2-weighted images telling us like that. But yes, preparedness for placenta accreta is the rule of the game now.
But you
And
said
for all patients,
40% are diagnosed, right?
Yeah.
Only
So
40%
low-lying
are diagnosed.
previous
Jyoti, your
section,
setup, how many are diagnosed before?
any patient of previous scar, previous surgery, low-lying placenta, we call back the radiologist ki accreta to nahi hai, accreta to nahi hai. So they look again and again. After 4 weeks, call again make sure that, and if there is slightest any chance that there may be, then go for further investigation unless it is ruled out. So we communicate personally with the radiologist and make sure that I do not get many just like walk-in. Mostly patients are booked. So high index of suspicion makes it rare that accidental accreta happens.
Actually, madam, in my opinion, we should now, like PPH, we should now all obstetricians be prepared for placenta accreta. Because it usually, though after all the investigations and getting MRIs done and everything, preparedness.
Partial accreta is many
very
times happens during surgery. Partial accreta we face that most of the placenta is removed, but some is adherent to the uterus. That is mostly missed in ultrasound.
Yes.
So what are the risk assessment for placenta accreta management? What is the risk assessment?
First is the number of cesarean section, earlier cesarean sections. If it is 1 or 2 or 3, as number increases, risk increases. Second is the location of the placenta, whether it is anterior or posterior. If it is anterior, the risk of morbidly adherent placenta is more.
And during delivery also, how do we manage such cases?
During delivery of placenta accreta, that is what the question is.
Yeah, Brenda.
Yeah. So that is a protocol to be followed in every case, that if it's a known case of placenta accreta, it is better for the patient to be taken under general anesthesia, because we expect trauma maybe in some parts. Bladder is always many a times very much involved. Then we have to sometimes search for the ureters also. And the dictum is not to touch the placenta before the delivery, means when the baby is delivered. So generally we open the patient by a midline incision, which is very rare otherwise. And we try to deliver the baby a little higher up incision given in the uterus. It may be a vertical or a transverse depending upon the comfort of the patient at that time. And one very important thing which we have made very essentially to be done is remove all the adhesions of the uterus beforehand. Because if you need a hysterectomy, then if the uterus is found to be adherent to the anterior abdominal wall, which is very commonly it is in cases of previous 1, 2 or 3 cesarean sections, then a very precious time is lost in just removing the adhesions while the placental area has started bleeding. So once the uterus is clear, the baby should be delivered by giving a high up incision above the level of the placental insertion. And once the baby is delivered, if possible, the incision is closed very fast. And then generally we have always made the patient and the attendants very sensitive that hysterectomy is the treatment of choice. After so many years of having done packing, having done focal resection, having done this and having done that for placenta accreta patient, now we have come actually to the conclusion that if it's a placenta accreta, if it's a placenta percreta, which is most of the times it is, hysterectomy is the treatment of choice, which generally saves the patients. And it's a war zone, of course. Even then, that's what I would like to say.
What is the massive transfusion protocol in such cases?
Yes. Massive transfusion. We already have arranged for 4 packed cells and of course FFPs, triodes, platelets. Generally, we arrange later. And yes, of course, a senior surgeon or a urologist has always been informed that we will definitely need. And a very peculiar finding that we find is the bladder is all spread across the placental bed. It has become so thin, the bladder wall, that most of the time we need the reconstruction kind of the bladder in these patients. Even when there is no bladder injury, the bladder becomes very, very thin and needs reconstruction. So presence of a urologist, and the case should always be managed by the senior most person of the unit. That is again the dictum. It should not be left ki khol lenge, uske baad jab bleeding hogi tab bula lenge. No, it's the precious time is lost. So that is what it is. Yes.
So the hemorrhage card checklist, you have to keep everything ready. Like all the instruments should be ready in OT, all the blood should be ordered, blood bank should be ready in providing you the readily available cross-matched blood. Then all instruments for cesarean, for laparotomy, and if needed, maybe urologist, you can call up the urologist surgeon also to help you out in cases of placenta accreta. So all such instruments, and these are always available in OT at most of the places. So, and all the drugs are mostly available everywhere. So we need not to worry. Even carbetocin, tranexamic acid, and this carboprost, misoprost. So we try with all pharmacological methods, and then we can go ahead with hysterectomy if there is intractable bleeding. So what else would you recommend, Jyoti, in such cases? Tranexamic acid, yes, definitely we give in all cases of cesarean. IV 1 gram to 2 grams is given. Yeah. Anything else?
Prediction and prevention, and then active management of the complication. That is you have to save the life of mother by all means.
So what is the obstetric hemorrhage checklist? Just give the headings. The IV access, medication, blood bank, the actions to be taken, and the documentation.
So this checklist should be readily available everywhere where we are delivering the patient. So we don't have to run for this at the time. It should be pasted in the labor room and in the OT where we are doing obstetric surgeries. And so that one after the, we are sure that we have followed all the steps, and no need to recall your memory at that time. It should be there.
One thing that nobody brought out here was that you need to have O negative blood ready. If you are expecting and the cross-match blood is not available, then O negative blood has to be transfused immediately.
And we normally get, if we order our blood bank officer, then we get the blood packed cell as well as FFP.
Ma'am, that is for planned cases. For unplanned cases, cases, you need to have O negative. You don't wait for the blood. Yes. So these are the initial steps. And then for uterine atony, what are the interventions that you have? The different balloons and sutures and all? What do you have?
And we use condom balloon. That's it. Condom balloon.
Yes. So you have an intrauterine balloon, whatever balloon you are using, but it is
but not in sufficient numbers. Bakri balloon is also available, but it is not available in sufficient number. So we prepare balloon by using condom and Foley's catheter. And it is
So
highly
balloon will
effective.
help in management, as well as if we have inserted balloon, inflated, and as hemorrhage has not stopped, then it is an indication that we have to go and open the patient and do a laparotomy and go
Has
further.
anyone an experience of Dr. Panikar's cannula?
No,
No,
not used it.
We have not
Seen
used.
it, but not used it.
Okay. So these are the, what is this?
Brace sutures and uterine artery, stepwise ligation of uterine and ovarian vessels. These should be available.
What are the lines? First, you might have to need to do a curettage, placental bed suture, uterine artery ligation, utero-ovarian ligation, uterine rupture repair, then B-Lynch.
Hysterectomy.
Before
That
that,
you have actually had to do a B-Lynch.
I have done stepwise devascularization in placenta previa, and that controlled the bleeding. B-Lynch I have assisted, not for my patient, but for a colleague's patient we have done.
And what is your experience with intrauterine packing?
I have done. If nothing is available,
we
that
used to do
also works.
intrauterine
That
packing.
also works. If there's
My
continuous
experience with intrauterine packing is dismal. You invariably lose the patient because that whole pack becomes sweat, aapko dikhta bhi nahi hai, and you
Depends on,
actually
yes.
lose. So,
Madam, here I would like to say something. That even it's a very pitiable thing that intrauterine packing does not find a place in the various management strategies for atonic PPH, and even to some extent placental adhesion where there is a focal adhesion, because in our hospital, rather in Gwalior itself, a tight intrauterine packing in cesarean section patients is one very good strategy. It is very easy to do. Only thing we have to ensure the PGs or the senior consultants or everybody that it is a tight intrauterine pack. If it's
three should go inside.
Yes. And
three roller
now you have
done it for 2-3 patients.
bleeding. You have a stage
No,
3 bleeding more than 1.5 liters. What are you going to do? One specific question I'm asking you, would anyone give crystalloids?
Yes. Crystalloids?
No. You don't give crystalloids. You only give initially, you given 2 bottles.
Yes.
When bleeding
After
started.
that, no. After that, no.
After that, no. That's what I'm saying. Now she's in stage 3. Now she's in stage 3.
After 2.5 to 3 liters, no more crystalloid, because it will increase the dilutional coagulopathy and it will increase the coagulopathy if we give further fluids.
Exactly.
We have to replace
this
blood.
Is part of the guideline. This I wanted brought out for the viewers. And you've given misoprostol, tranexamic acid. Nothing has worked. You've given the Bakri balloon, didn't work. You gave B-Lynch, didn't work. Did uterine artery ligation. Did a hysterectomy also. She's still bleeding. Now what? She's now in collapse. She has massive hemorrhage, hypovolemic shock, or amniotic fluid embolism. What next? सब हो गया उसका. आपने अपनी तरफ से सब कर दिया है. She's still bleeding.
No, after hysterectomy,
ligation should have been done right then only.
Yes, ma'am.
Internal iliac ligation should be done generally.
आपने सब कर लिया, वो फिर भी bleed कर रही है.
अच्छा, सब कहाँ से bleed कर रही है अब वो?
Ward
Because hysterectomy has been done.
Ward से सब जगह से bleed कर रही है.
She's in DIC now.
She is in coagulopathy. She's in coagulopathy.
Intensive care. Intensivist and hematologist and all will, and then we have to talk to the relatives also.
Replacement works wonders, madam.
It may be because of ITP or TTP. So in such cases, they give high doses of steroids also, and such patients should be managed in ICU under care of intensivist, as well as in all such cases of intractable bleeding. You can also try with giving activated factor 7 concentrate for controlling the bleeding. So this way, and giving cryoprecipitate is also important. Giving FFP and single donor platelet is also very important in controlling the bleeding in all such cases.
So
We
now
can do abdominal
somebody has
abdominal
refused कि हमको blood नहीं लेना है. They refuse कि हमको blood चाहिए ही नहीं. What do you do with such patients?
Then lower threshold for all interventions.
Yes, that is the most important thing, that you have a lower threshold for all interventions. So, anybody would like to conclude?
Madam, it's a nightmare. PPH is a nightmare. And once it happens, you need help. You will not have the courage to manage. Even if you know perfectly everything what has to be done, you need help. You should not hesitate in calling help. Immediately raise an alarm and call people who will help you to manage this patient, if you want to save the patient.
I want 1 point from every person before we actually end the webinar. Brinda ma'am?
Yes.
Just 1 word of caution to everyone.
For PPH?
Yes.
Be alert, attentive, and active. Because PPH is there to stay.
Patient after delivery should not be left like that. Ki ho gayi delivery. Every patient should be very closely observed, at least for, even if you have come home, call back the sister, patient theek hai, ek baar pulse dekh lo, BP dekh lo, bleeding dekh lo. We have to call and we have to ask for the parameters. Till we are suturing episiotomy and closing the abdomen, we are there for half an hour. But even after that, at least for 1 and 1.5 hours, we should be vigilant for that patient.
And madam, even after that,
someone is saying that patient is lying in a pool of blood. Nobody has observed.
And madam, even after that, in a medical college setting, I have seen that even a small trickle of the blood that is happening afterwards. Means apparently, if you do an abdominal examination, the uterus appears tight. But this should be maintained in a clear watch that the patient is using more than normal vaginal pads. And if you open the vulva, then there is a constant trickle. That line is always there. It's not
paraurethral tear will bleed all night.
Yes, yes. And then the next morning you will find her breathless, and then you will consider it's because of embolism. But actually it was because of the chronic blood loss. That is another very important thing to be discussed in PPH. That is why I said alert, attentive, and active in taking decisions.
And in all the cases of deliveries, we should use the uterotonics very frequently. Like in all the cases, we should use it. Oxytocin, sometimes if needed, carbetocin also can be used. And sometimes we do use carbotrost, particularly in cesarean section, and tranexamic acid. It helps in controlling the bleeding. So we should try and control whatever patient is bleeding by judicious use of all such pharmacological agents. And we should not leave the patient after delivery. At least for 1.5 to 2 hours, we should watch the patient, or maybe the staff should watch the patient and see for the bleeding, and any injury, any coagulopathy, if it is there, should be treated accordingly. So all patients need proper care, attention, and during pregnancy and intranatally also, and postnatally also.
Thank you, ma'am. Dr. Renu, you want to say something? 1 line.
When PPH may occur even without the presence of risk factors. So each and every patient which is delivering in our labor room or we are doing cesarean section, we should be like कि PPH किसी भी patient में हो सकता है. तो हर patient को हम seriously ही देखना चाहिए.
Shruti ma'am, आप बैठे हैं अभी तक. Would you like to say something, please?
Ma'am, I'm loving the discussion. और क्योंकि आप रायपुर से हो, मेरे मायके वाले हो, तो मैं तो मायके के मजे ले रही हूँ बिल्कुल. आई एम वेरी हैप्पी. द वन थिंग ऑल्सो मेरे को चाहिए कि जो अपन वैजाइनल डिलीवरीज कराते हैं, इन ड्यू कोर्स क्या हो जाता है, अपन बहुत ज्यादा स्टाफ पे रिलाई करने लग जाते हैं. कुछ स्टाफ इतना बढ़िया ट्रेन हो जाता है कि अपन उसकी बात पे भरोसा करने लगते हैं. तो वो भरोसा एक लिमिट तक ही करना होता है. दिस इज व्हाट आई हैव लर्न्ड विद एक्सपीरियंस, कि उनकी बातों में भी ढूंढो कहाँ वो लोग एकदम कॉन्फिडेंट नहीं है, एंड देन गो फॉर इट. वहां पे गड़बड़ निकलती है. हाँ मैडम नहीं है, हल्का सा है, ठीक है, इसको नहीं लेना, देखो उसको. दिस इज व्हाट आई हैव लर्न्ड. क्योंकि वो जो स्ट्रीक की बात मैडम ने की ना, दैट इज रियली स्केरी. वो एक स्ट्रीक आते रहता है, आप स्वाब से पोंछते हो, फिर आते रहता है, फिर स्वाब से पोंछते हो, फिर अच्छे से खोल के देखो तो 3 o'clock में कहीं टीयर दिखेगा, फिर उसको रिपेयर करो, तब आप चैन से सो सकते हो. This is what my experience is.
So, thank you. Thank you. You
I
all
want to
know-
say a few things. Ma'am.
Yes, Dr. Shabana,
Ma'am.
welcome.
Ma'am, Bakri balloon and other type of balloons, actually we are using very frequently. So I have a command that कई बार ये obstetric hysterectomies बचा लेते हैं मैम. Mechanical method is giving wonders. Rapid, quick initial assessment of the patient and a good teamwork and a clear instruction to the team in quickly managing PPH within golden hour is a basic, funda behind this. And ma'am, something
One
like
more
this.
I want to add, you know,
yeah.
that is
please add.
placenta accreta. Dr. Mahesh Gupta sir had come. He said, if you know it is a placenta accreta, it is easy to do a hysterectomy. But you can also do a conservative surgery, remove that affected part of the uterus.
Yes, yes. We did
So
3
just
surgeries,
do that.
triple P procedures.
No, not B-lynch.
Okay.
जहां पे चिपका है प्लेसेंटा उतना काट के निकाल दो.
Triple P procedure.
निकाल दो. That's it.
Triple P procedure, yeah. Another
That's
thing,
it.
ma'am, there are few garments are coming. These are for the referring doctor. That is anti-shock garments.
Yeah.
So nowadays, Government and Jeevdya Foundation, they are providing this to the district hospital and to the medical colleges. And it's a time saving. Like we want to shift the patient to the OT and the patient is in grade 4 shock. We can just make it wear and it's pooling of blood from periphery to the vital organs, and we can shift to the OT and then save that patient by arranging blood and by managing. So these are few points I want to add.
In the end, I would like to say, you know, what Vrinda ma'am said, be alert. Be alert, find out what's wrong and, you know, act on it. That is the ultimate thing. And what Jyoti said, earlier rather than later.
Yes.
Always earlier rather than later, because that is the only way we are going to survive. And don't trust your staff over much. You have to
Make them trained.
do.
Make them trained that they should learn that a small trickle is also very important.
Yeah. So thanks a lot. Thank you, all of you, for being here. We are not very late, only 10 minutes late. So thank you. Thank you for being here. And I request your support for my candidature for Food, Drug and Medical Surgical Committee. All of you who are present now, who
All
will
the
come
best
in the
and
future.
congratulations in advance, ma'am.
Thank you, Dr. Shruti. Please help out. Okay. And Corona Remedies, thanks a lot, Corona Remedies. I thank all the guests, the chairperson, my co-moderators, the panelists, and all the viewers for being part of this. Thanks a lot. See you again one more time in the future. Thanks a lot.
Thank you so much for inviting us.
Piyush, are we done?
Thanks a lot. Thank you, Dr.
Yes, ma'am. We are done. We are done.
And
Can I close the meeting?
You